Bismillahirrahmanirrahim. My name is Dr. Kamran, Shaikh, and I'm a consultant psychiatrist in England, UK. So today's topic we are covering is rapport, communication skills, and empathy, a brief review. So whatever we will talk today, I will pay my tribute to my teachers and then my grand teachers, like my mentor, Professor Nasir Said Khan, Professor Rubina Aslam, and others. And then and recently one of the professors has passed away, so we pray for his forgiveness, Professor Malik Hussain Mubashir. So let's start with today's lecture, and I must acknowledge that I have taken many things from Professor Nasir Khan's lecture and also from other sources which will be mentioned in the last slide. So let's go to the frame 2, which is our PDF. And so rapport and communication skills. So now what happens in the first thing, first of all, you have to take consent from the patient. Now, the Royal College of Psychiatrists, when you are appearing in the CASC exam, that means that's understood that you have a consent and like consent to talk to the patient, and even with the relatives, it is for granted that you have the consent. But it is good practice to mention, if you're talking to the relative, that I have the permission to talk to you, and the permission was given by your son has given permission, your daughter has given permission, your father has given permission to talk to you. So the father is the patient, and now you're talking to the son, who is the carer. So, but some colleges, especially with the undergraduates, they say that you should take the consent to talk to the patient and checking identity. So you go with your own college protocol, whatever your college suggests. You go with that. And also checking identity. And it is more important when you are talking to the phone, especially in the COVID season, if you are making a phone call and you're not able to see the other person. So it's good to check the identity. Am I talking to such and such person? Yes. And as a good practice, you can ask the date of birth. But if you are so familiar with the patient is familiar with you, just double check that, yeah, am I talking to Andrew? Am I talking to John? Am I talking to Samir? Am I talking to Khalid? And if you're sure that it is Khalid at the other end, just continue. Now, the next slide. So rapport. What is rapport? So rapport means that the patient feels comfortable talking about their problems to you without hesitation, and the patient is able to make a trust in you, so they can trust you, and they can so they're able to build their trust in you, and they know that you are the person who are able to help them. So harmonious responsiveness of the physician to the patient and of the patient to the physician. That's another definition given by the Royal College of Psychiatrists, and this I taken from the podcast by the name will be mentioned in the last slide. So there's a podcast which was done in 2006. So I took it from there. So it's important that the patient increasingly feels that he's being understood and listened to, and the evaluation is a joint effort. So basically, you and the patient, you both are working on the same agenda. You are exploring, you are trying to reach the root cause of the problem, which is causing distress to the patient. Now, he should feel that the psychiatrist is truly interested in his story. So that's what Professor Nasser said in his lecture, that the psychiatrist is taking interest in his story. And now when we come to the communication skills, we'll discuss how to do that. So the parts of the rapport is dress well. So any dress, but it should be formal. Like Professor Nasser was saying that like even you can wear shalwar and kameez, but make sure you have a waistcoat on it, or if you are like formally dressed, if you are and so very neat, clean new shalwar kameez and a neat, clean waistcoat, or otherwise, if you are wearing a suit, you can wear a suit. So trousers, shirt, tie, coat. So, and be very neat and clean. Be polite. Mirror the patient. So mirror the patient means that if I'm talking to the patient, mirroring means that okay, so the patient is saying, "Doctor, I feel like dying. I don't feel like living." Now your tone of the voice should also go very low with this. When the patient is saying that they feel like dying, also say, "Oh, that must be really distressing. I can imagine you're feeling so low." So both patient and the therapist are talking in the same tone. Or if the patient is a bit loud, "Oh, doctor, you are joking with me." And then the doctor replies, "Sir, I'm not joking. We are here to interview you, and this is the part of the interview. So, and we'll take all your suggestions, all your whatever you say very seriously. We are trying to help you." So here you are talking in a normal tone. Now, give importance to the patient. So you are talking to a human being. You're not talking to a machine. So the patient is important. An unconditional positive regard. So no matter who is sitting in front of you, whether the person may confess that he has done 57 murders, or they may have alternate views about their sexual orientation, religion, culture, but you have to show unconditional positive regard. And that's one of the things we take oaths when we become doctors. That's one of the things of consist in the Hippocratic Oath. Now, be positive and choose your words carefully. So get in a positive habit. Like, don't say negative things. So and choose your words very carefully. So choose soft words. Like, you can say, oh, I know you're having a big problem. And you can also say, I know you're having some difficulties. So some difficulties, or you have, will be suitable to one person under some circumstances, and a big problem you can use in other circumstances. So generally you should use softer words, but sometimes you might have to use harder. But choose the words, your sentences very, very carefully. And now be honest. So never ever give false reassurance. So you should be reassuring to the patient, but avoid false reassurance. And also model your seniors. And I'm on also one of the things in introjection. So introject good habits from your seniors, from your consultants, from your senior registrars, and so that should be the spirit. So and believe me, modeling and introjection of the style sometimes helps, and sometimes it is unhelpful. So in the CASC, if you are introjecting a consultant who is doing things fast, who is doing things like, we're doing a lot of things comprehensively in a short span of time, very quickly, model that consultant. And if you are modeling, for example, a psychotherapist who takes a session about 1 hour and 30 minutes, and they are focused mainly on communication, and they complete the task very, very slowly in 1 hour or 1 hour 30 minutes, then in that case you may lose time, because in the CASC situation or in the TOACS situation in FCPS, you have to build things quite quickly and quite rapidly in a short span of time, which is usually 7 minutes and usually 6 minutes even, and the last 1 minute is to wrap up. So you have to cover a lot of points. So introject some or model some senior who has a habit of doing things quickly, just for the sake of exam. And after the exam, you can introject any good habits of any consultant, or even if the psychotherapist, you can model. If you have time, then goes very slowly, and that's fine. Okay, the next slide. So communication skills. Now we come to try not to interrupt, but sometimes in the CASC exam or in the TOACS exam, you have to interrupt because of the time. But in generally try not to interrupt at all, and try to break into the pauses. So if it is a long case, for example 45 minutes, and you know that the patient is not taking less than 3 hours, then you have to interrupt in the pauses. And similarly in the CASC or the TOACS or the OSCEs, you have to interrupt in the pauses. So For example, if the patient is saying, "Oh, doctor, the flowers are red and they are really beautiful flowers, and basically I was going into the garden and garden was so lovely and enchanting, and it was morning time, and then I saw a gardener." Now, when he said gardener, you go into there. So you're telling me about the flowers. So they were lovely and they were red. How many flowers were they? And how did they look like? And was there any, now you want to establish if there was a paranoia. Was there anybody apart from the gardener? And did you hear any, did you have any strange experience in the garden? So now you have to interrupt carefully, breaking into the pause, and it shouldn't appear to the examiner that you are trying to interrupt. So breaking into the pauses. Now try to say something. So yeah, I mean, it's a good balance. Sometimes you let the patient speak and you lose control, and sometimes you speak too much and the patient feels that he's not able to say, or he's not able to narrate his or her story. So you have to make a balance between the two approaches. And so take the control and start the questions, and then let the patient speak. So let the patient speak in the answer of a question for 1 to 2 minutes. I'm talking about in the general routine, not the CASC, but 1 to 2 minutes. Then ask some closed questions. Then ask another open-ended question. Then give them 2 or 3 minutes or even more. But in the CASC or in the TOACS, you just give the first 1 or 2 minutes to the patient, and then you start with a bunch or a mix of, or a blend of open and close-ended question. So never be sarcastic to the patient and do not appear to be in a hurry. So if you are asking closed question one after another and you are ignoring what the patient says, that means that you are giving the impression that you're in a hurry. So don't give that impression, but give the impression that you are listening to the patient, and then you are gradually bringing them to your questions. So two-way interaction is so important. And so make a compromise between patient's agenda and your agenda. The patient wants to tell the social side of story and the etiological factors, and they may go about their office situation for hours and hours and hours. But you are more interested in how is the patient sleep? Are they waking up quite early in the morning, or are they having any early morning awakening, diurnal variation, things like that. So that's what you are interested in. So make a compromise between the patient's agenda and your agenda. Like, just giving the example now, I'm trying to make a compromise between my video and my slideshow. So because I want, one part of me wants to show the video to you, and the other part wants to show the slideshow to you. And I've tried to combine the both. So that, in the similar way, when you're talking to the patient, you make a compromise between you want to elicit. You have a diagnostic approach, and then you want to cover all the etiological factors, even including the negative ones. And the patient is focusing mainly towards their preoccupation and their one or two positive etiological factors. So weaving or zigzag technique. So in weaving, and this is the thing I learned from Raja Natharajan of Oxford Psychiatric course. It's an excellent course. And they tell you the weaving means that there are two needles. So you take the thread from one needle, and then you take the thread from another needle, then this needle, then another needle, this. So basically, weaving means that you are putting your own thread to make the jumper, to make the sweater, to make the pullover, and the patient is presenting their own thread. So unless you combine, this is the right one is the my thread, and the left one is the patient's thread. And unless you combine both the threads, you're not going to make a good looking pullover. So you have to combine the things in a two-way manner. If you are just putting your threads or your questions, that means that you're going to spoil the sweater. Or if you are taking only patient threads and not speaking at all, then that means again the sweater will be spoiled. So you have to be two-way, and patient talks about their problem, you ask your own question, and you interrelate. So zigzag technique, that's what Justin Zor, one of the examiners, he told me. So zigzag technique, like you go your agenda, then you divert toward patient's agenda, then you come back to your agenda, then you divert towards patient's agenda. So that's how you go zigzagging, or what I call tennis technique. So tennis technique, what I mean by this is that you are playing tennis. So you have to throw your own ball, and then the other player is throwing their own ball. And it's an interactive thing. So unless you make it interactive, it won't work. So both, like you have to throw the service and they have to play, and then you have to interact. Or similarly, you can say like a cricket. So one person is bowling and you have to respond to that ball, otherwise you will be out. So you have to respond, you have to bat that ball. Helicoptering concept, use sparingly. Helicoptering means that if something is kind of unacceptable or not helpful. Now 99% of the things will be helpful, and you have to take clues from those things. But asking, where did you qualify from? So in that case, if you become annoyed, that won't be helpful. For example, if you say that, well, I don't want to tell you, it's not about me, it's about you. So, or if you just ignore, oh, doctor, where did you qualify from? So you ask Jenny, please tell me about your sleep. You're ignoring what the patient says. So the helicoptering technique will be best. You will say something, Jenny, I know you are very interested in where I got qualified from. Actually, today we are focusing towards you, and we are trying best to help you. So you are the most important person today, and it would be helpful that if we talk about you in today's session, and I can tell you about myself at some other stage later on, I hope that should be okay with you. So that means if you're playing a chopper game, for example, a chopper game in your mobile or in any app. So in chopper game, for example, the helicopter is going, and then suddenly some hurdle comes. Now, if you strike the hurdle and you fall down, and you lose the point, you lose the round. But if your chopper is going like that, and there is the hurdle, and then you go above the point, and then you go, and then you're seeing the whole city. And so let's say now this is the city, and you are trying to land where you want to land. So that's the helicopter technique. You go above the hurdle, first step, and the second step is you land where you have to land. Then open versus closed questions. So some people say toning down the question, and yes, it is very helpful that mostly open-ended questions in the beginning, and then towards the late it will be close-ended questions. But I would say that it's in the same interview, in the 45-hour interview, you have to tone down a number of times. So it's not only once, but a number of times. Sometimes you go open-ended, then close-ended, then open-ended, then close-ended. But generally, open-ended, more open-ended during the beginning, and a little bit more close-ended towards the end. And more sometimes, now what happens is, patient is not opening up. And you say, you go to the CASC station. The basic mistake the people make is that they say the patient is not cooperative. And you say the actor is not cooperative. The basic, and again I owe this to the Oxford course and also to my mentor Sashni Mudlia, who told me. So always think that you are talking to a real patient in the exam, even if they are actors, but never ever think that they are actors. They are real patients. And believe me, when I was doing my PLAB exam many years ago, and I remember like a patient who was so good at acting for a depressed patient, and I literally, I can't, even if I recall now, I can only recall that she was a real patient, but in fact she was a role player. So take them for real patients, real actors, real relatives, not actors. So real relatives and the real kind of relatives of the patients, or if you're talking to a registrar, real doctor. So take their role as real, and also your role as real as well. This is what Oxford course told us, that we are not candidates. In the exam, we are not candidates. We are, so what we are then? We are doctors. And when you are introducing yourself in a CASC exam, or in any exam, introduce yourself as one level senior. So if you are going to the CASC exam, introduce yourself as a psychiatrist. Or if you are a medical student, introduce yourself as FY1 or a house officer, foundation year doctor. So if you're going to the like MRC Psych finals, the CASC, don't say that you are a junior doctor, because they're expecting, the examiner is expecting that can you function at a higher level than this. Same with the medical student. Can you work at a higher level? Can you practice as a doctor? So don't introduce yourself as medical student, but you can, but it's better if you introduce yourself as a doctor. So what I was saying, the patient is not cooperative. That's where I took the turn into the candidate mode versus doctor mode, and then the role player mode versus patient mode. But the real thing we were discussing was that what if the patient is not cooperating? So if the patient is not cooperating, there could be 101 reasons. That doesn't mean that he's not cooperating. That means that the patient is not able to trust you. The patient may have mistrust. The patient may have a learning disability. They may have negative symptoms of schizophrenia. They may be so depressed. They may be terribly anxious. And they may be so paranoid that they can't trust you. So they become guarded. So they're not consciously becoming guarded. It's their unconscious. How to tackle with that? And I would say loads and loads of closed questions are so important in this case. No. So a number of closed questions. Again, phrase each closed question quite tactfully. So kind of don't phrase like, okay, how's your sleep? How's your appetite? So you have to name the patient. Jenny, so would you like to tell me how you're sleeping? Let's see. What time you wake up in the morning? Can you tell me about your sleep? The patient may not tell you. Okay, what time you go to sleep? And what time you wake up in the morning? Are you able to sleep throughout? Or do you wake up? And if you wake up, are you able to go back to sleep? So you have to, I know it won't be very easy when you wake up in the middle of night and you have nothing to do and you keep on thinking. So tell me, what do you do when you wake up? Do you keep on thinking? Try to avoid leading questions, but sometimes, especially in the learning disabled population, you have to ask. So, do you smoke, or do you read, or what do you do? So basically, again, an open-ended question comes again. What do you do when you wake up? And if the patient is not opening up, so sometimes people keep on thinking, is that what you do? Sometimes people make a cup of tea when they wake up. Do you do that? Sometimes people smoke cigarettes. Do you do that? So that's what you do. It's a mix of open-ended and then number of close-ended questions. Phrase carefully and try to relate one question with the another. In those patients who are not opening up. And please don't try to, in which we, in Urdu or Hindi, we say, okay, minnatein karni. So don't try to insist the patient, please tell me, please tell me what's wrong with you. Would you please tell me? It will be really helpful. If you tell me, I will be able to help you. I won't be able to help you if you don't tell me. So once or twice, that's fine. But if the patient is not opening up, come to the closed questions straight away. Okay. The next one, so that's the communication skills, so now if the patient is mute or withdrawn or guarded, go on asking close questions one after another in an empathic way. Your tone of voice is very important here. Phrase close questions very tactfully. Be exploratory and very tactfully inquisitive. Investigative style. So you have to investigate and you have to explore. So why did this happen? What was happening then? And how? So for exploration, how, when, what, where, how much, how many, these questions are so important. And you have to make things clearer and clearer in order to reach some diagnosis, in order to reach some etiology, or in order to explore the differential diagnosis. You have to explore things, especially for the reason of referral. So who sent you here, and who booked the ambulance, who phoned the ambulance, and so your husband phoned the ambulance. Who told your husband that you have taken an overdose? What time was it? And was it night time? So were you trying to hide anything from your husband? And was he present at home, or did he just come at home at that time? So those reasons for referral. And who was the first person you contacted? Did you contact the GP? What led you to contact the GP? So this should be crystal clear, especially the reasons for referral, that where and who and how, like why now? Like my mentor, one of my mentors, Dr. Iris Gibson, she used to say, why now? Why this problem, and why this person is suffering, and why this problem he's suffering from, and why now, why at this time, why not at other times? So reflective listening. So reflecting, I many times I tell my students, and they do pick up on it, reflective listening. So the patient is saying, doctor, my sleep is disturbed and I feel very tired. So the patient has told you two things in one sentence. I feel very my sleep is disturbed and I feel very tired. So you just ask them. So you told me that your sleep is disturbed and you feel very tired. So let's talk about the sleep first. So can you describe your sleep in a few words or in a few sentences, if you don't mind? Okay. And then you explore the early morning awakening. And then tell me about your tiredness. So what time you feel more tired? And generally, do you feel, I see, so you feel more tired in the morning. So in the morning, do you also feel very low in your mood, very sad, or not? So complete your checklist without giving a conspicuous impression to the patient that you are completing your checklist. You have to complete your agenda, but it doesn't appear to the examiner or even to the patient that you are completing your agenda. It should appear that you are just having a conversation, a chat with the patient, but inside you know what buttons to press, what questions to ask when. And you have to ask those questions at right time, but it shouldn't appear to the patient that you are asking one after another question. So that's an art. So basically, show you the this number 2. So complete your checklist without giving a conspicuous impression to the patient that you are completing the checklist. And the next thing is knowledge-based communication. So the knowledge-based communication means that give a menu of options: biopsychosocial, multidisciplinary team, care plan, care program approach, CPA, carer assessment, stress, where the patient would go, housing, and then going to a supported accommodation, going back to the family home, interdisciplinary, liaising with the GP, collaborative approach, and give facts and figures. And do not be very wrong in your facts and figures. If you don't know, then make an intelligent guess that most of the people suffer from this, or a lot of people suffer from this. It's very common. Say something like that. But if you know the facts and figures, present those. So symptoms first, and then diagnosis. Then a cluster of symptoms again. So when you are giving the diagnosis in a station which is the explanation station, give the symptoms first and then the diagnosis, and then the cluster of symptoms again. So like you said, so your son was having voices for about 3 months, and he was behaving very strangely, and he wasn't able to look after himself. He was very irritable. So that all happens in a condition called schizophrenia. Have you heard about this condition? Check with them. So I explained to you, schizophrenia has kind of 2 types of symptoms, meaning positive symptoms and negative symptoms. Positive means that having something unusual which other people don't have, and negative means that not having those qualities or those things which a normal person should have. So for example, I explained to you, for example, the positive symptoms may include that having false beliefs, which we call as delusions, or hearing voices or noises, or seeing things, or having any other unusual experiences, which we call as hallucinations. And also amongst those are what we call as derailment of thought, or means that their thoughts get quite muddled up and they are not able to organize their thoughts. Now we come to the second category. Are you clear about the positive symptoms? Okay, so we come to the second category, which are negative symptoms, means that they lose motivation, and they don't have any motivation to do anything. They remain tired, they stop socializing, they stop speaking, and they don't look after themselves. And that's what we call as negative symptoms. So when these symptoms are there for about 1 month, and there is no other reason to explain those symptoms, then we can say that it's schizophrenia. So, and then universal checklist for history, mental state, examination, explanation station. So we'll come back to this some other time. I will tell you what checklist to make. Now, the next one is empathy. So this is our like the last topic of today, and let's see the clock. So it's 45 minutes so far, and we are on the 8th slide. So empathy means affective or emotional response which is more appropriate to another person than one's own. So like you put the person in patient's shoes and see and sit in the patient's chair and consider that you are talking to a doctor and you are a patient, and how would you feel? Or apply the mother rule or father rule, sister rule, or a VIP rule, because all the patients are VIP to you, whether they are poor, rich, or male, female, elderly, or younger. Everyone is VIP to you. So apply the VIP rule. Would you say something to a VIP? And how would you communicate? And sometimes these TV talk shows help you because these anchor persons or these compeers, these hosts, they show good communication skills. Especially some of them have very good communication skills. So empathy is understanding that what the patient is thinking and feeling when the therapist puts herself in the patient's place while at the same time maintaining objectivity. So it's so important that you don't lose objectivity. You don't become judgmental. The patient is saying that, like if the child is saying, oh, my principal is very strict and my teachers are very mean, and there are children bullying in my class. So if you start saying, oh yes, most of the teachers are like this, or students are like this, oh, the principal, I know the principal. No, don't say like that, because otherwise they are going to quote you that, yes, doctor was saying that you are a mean principal. So why to say that? So don't make any blunders in being judgmental. So you have to say, oh, I know it must be hard. So tell me a little bit, how do they bully you? So that must be making you feel very miserable and very worthless. Am I right in saying that? How does that make you feel? Oh dear. So compassion in a positive and helpful way. So now I haven't said anything against those boys, but I'm concentrating on patients' emotions. And similarly, I haven't said anything about the teacher. I could ask, so how does the teacher handle? I see. But don't say, oh, your teacher is handling it very badly. They shouldn't do that. No, don't say like that. Don't be judgmental. Compassion in a positive and helpful way, and kindness and soft-heartedness. And psychiatrist has to be very observant throughout. Read in between the lines. Meta-representation, that's what the Royal College podcast said. And pick verbal as well as non-verbal cues. So if the patient, for example, the patient is kind of saying something that if the patient is trying to stare at some place, you pick it. So what made you feel like, what made you look at the walls or outside? Did you see something? Tell me about that. What was it? And how did it make you feel? How many were they? Okay, so that's the non-verbal cue you are taking. Or if the patient is wearing a turban in an unusual way, I can see you're wearing a turban. So is that you usually wear all the day or every day? Was there any specific reason? Oh, I can see you're wearing a lot of lipstick today. You're very well dressed today, actually. So pick it in a positive way. Don't make it look like sarcastic at all. So, and similarly, verbal cue. Doctor, for example, if the patient says, it's been ages when I was happy. So you just ask, so what do you mean by ages? It looks like that you haven't felt happy in a long time. Am I right? So tell me about that. Or if they say, those people are, well, I am feeling low because of those people. Now you may ask about, for example, so tell me about your sleep appetite. But no, he has said something, those people. Pick up that cue and ask, who are those people? Tell me about them. So take those cues, small cues, and then address, and then if you have to ask something else, come back to say that I'll come back to, you have mentioned some people, and I'll come back to those people, but let me ask you 2 or 3 more questions, and then come back. But it is good practice to explore the cue there and then, and not delaying it. Okay, so the next would be, for example, so the pick verbal and non-verbal cues. And if the psychiatrist is not certain about the patient's experience, it is important not to guess it, especially in the beginning. So therefore, non-verbal empathy will be more important in the beginning, and later on verbal too. So in the beginning, you can say, oh dear, oh, I'm really sorry to hear that. And then when you get a sense of what the patient is saying, then you say, oh, that must be really displeasing to you. That isn't easy. That is difficult. You must be a brave person to bear all that. But elicit like after 2 or 3 minutes, then express this verbal empathy when you are able to make the right guess. If you are able to make the right guess from the beginning, then say it in the beginning. And if you're not sure how is the patient feeling, then say, how did it make you feel? I know that feeling mustn't be an easy feeling. So how did it make you feel? So they can say, made me feel very angry. Sometimes you say, oh, it must have made you feel angry. And you say, I wasn't angry, I was upset. So then it doesn't give you very pleasant interaction. So you say, how did it make you feel at that time? And then if they don't say, you might have felt angry or upset. So that's how you can approach the empathy. So empathy is effective or emotional response which is more appropriate to another person than one's own. What psychiatric disorders it is lacking in? So autistic spectrum disorder, paranoid schizophrenia, psychopathy, narcissism, obsessive compulsive personality. So if you are sitting as, you shouldn't come across as having those things. So you should, especially, you shouldn't come across like this or like this. So you should come across like a doctor who is really caring and patient-centered, and who is there to help. So show your empathy both in words and non-verbally. Now, the various components of empathy: perspective taking. So that means the first is that you take patient's perspective. If I was in his place, how would I feel? The second is reproducing or sharing the emotional state of the other person. That's the second kind of the component. So we do take perspective, but sometimes we are not able to share that. Say something, or mirror the patient. Oh, I'm sorry. How did that happen? So you're whispering. That's a kind of non-verbal or semi-verbal kind of or leaning towards the patient. Okay. Or if I'm holding a pen, dropping the pen. So what happened then? Oh. So that's how you share the empathy, go with the empathy. So, and then the motor empathy, non-verbal, posture, gesture, expression, unconscious. So verbal, non-verbal, and perspective taking. All three components should be shown from time to time. And please use the words, please use the sentences where appropriate, so that the patient knows that you are empathic. And then, so neurophysiology of empathy. So you can see in the slide that amygdala, insula, and different parts of frontal and temporal lobes are involved in empathy. And then coordinated brain processing are there, mirror neurons. So, and lack of empathy may be secondary to the lack of theory of mind. For example, in autistic people. So don't take them as psychopaths, although autistic psychopathy is there in some individuals, but mostly the genuine, pure autistic people, they lack the theory of mind. Okay, and then disorders of lack of empathy we have covered. So how to demonstrate and elicit empathy? So non-verbal communication, very important. Facial expression, gesture, body habitus, posture, disposition. Sometimes you sit like that, sometimes you lean forward, sometimes you mirror the patient, and sometimes, so prosodic feature of language, pitch. So your voice may differ and may vary from sentence to sentence. Rhythm, voice, music, melody, volume of the voice. Techniques of showing empathy. So it's important that doctor-patient relationship is established. Patient feels that he is being understood and being listened to. Non-judgmental approach, unconditional positive regard. Apologize, admitting a mistake. Don't over-apologize, but once apologizing, if there was a genuine mistake made by you or your subordinates or your team members, just make an apologetic statement and move on then. So, deflecting the personal question tactfully, exploring, try to avoid giving samples, otherwise you may lose objectivity. And comment on emotion more than the thought. So, like, how did it make you feel? So don't say that what thoughts. I mean, you in the CBT you will ask what thoughts were coming into your mind, but generally, how did it make you feel? that must be very upsetting. That must be frightening for you. So concentrate more on the feelings. And then now sympathy versus empathy. So sympathy and empathy, when we come to the dictionary, they are synonyms. So sympathy is something suffering. Empathy has a broader concept. So sympathy means that you are suffering. Empathy is a global, broader concept. So it is not only the feeling of that suffering, but also the other components, showing that verbal responses, non-verbal responses, and sentences, body posture, motor responses. So all these things you have to say, and that is when you are showing the sympathy in a formal and required way, that is called empathy. So sympathizing is a relatively brief concept, although in dictionary they are synonyms. But when an empathy is more kind of a technical word, more broader concept, and generally in layman terms they are synonymous. So now sometimes we don't use the term sympathy because sometimes it is used in negative way as well, or in a sarcastic way, like if a son fails in 3 consecutive exams and the father says, "Oh, my son, I have all the sympathies with you, failing again and again." So that's a sarcastic way. Negativity is there. But generally, it is used positive most of the time, but sometimes negative, while empathy is always positive. So in sympathy, that could be looking down, negativity, pity. And if these 3 elements are removed, and if the sharing of sympathy and saying something about those sympathetic feelings in a positive way, then it becomes empathy. So it's a broader thing. Like sometimes there are things which are negative. So jealousy versus, like jealousy is always used in a negative sense, while envy, sometimes you use it synonymously with jealousy, and sometimes you say that kind of envy is both like sometimes you say, "Oh, I envy you. You're a great person. I wish I could have guts like you," and really admire it. So you're saying it in a positive way. So envy could be both positive and negative. Similarly, if you're saying motivation for success, it's a positive thing. And if you're saying greed, that's a negative thing. So empathy is purely positive word, while sympathy can have sometimes a negative meaning as well. And that's why in clinical settings we use the word empathy instead of sympathy. So and then let's see the dictionary definitions of sympathy and empathy. So the dictionary.com defines empathy as psychological identification with or vicarious experiencing of the feelings, thoughts, and attitudes of another. Then imaginative ascribing to an object as a natural object, work of art, feelings or attitudes present in oneself. So by means of empathy, a great painting becomes a mirror of the self. So it's a broader concept. And the synonyms, so when we come to the dictionary synonyms, it also includes somewhere here it will be written as sympathy. So pity, rapport, sympathy here. And similarly, now the next slide, sympathy. What is sympathy? So harmony or agreement in feeling as between persons. Now another thing, we don't agree, we don't become judgmental. But if you are sympathetic, sometimes you become judgmental. Empathy is you have to remain non-judgmental, objective, and unconditional positive regard, and you are focusing towards the person's feeling. While in sympathy, sometimes you can go into agreement, so you don't have to show your agreement to the patient, and that's why we don't use the word sympathy. We generally feel the word empathy. So the harmony of feeling naturally existing between persons like tastes or opinions of congenial dispositions. So in general, if you're talking to a friend or gossiping or something, you may show sympathy and then you may agree. In empathy, you don't have to. Okay, so feelings of favor, support, or loyalty. So it's more kind of subjectivity is there, and in empathy is more objective term. And then synonyms for sympathy. So again, you can see that empathy is there as a number 3. But the delicate hairline differences I've explained to you, and I've explained to you that why we use the empathic and the term empathy rather than sympathy. Now, what are the empathic gestures? So empathic gestures means head nodding. So let's put my camera on. 1, 2. So head nodding. Yes. Or putting down pen. So if you're writing and patient says, "Oh, doctor, 2018 was a horrible year for mine, and both my father and mother died that day." Now hearing that, you put the pen down. "Oh, I'm really sorry to hear that. So your father and mother both died within a short span of each other. How long was the difference?" So leaning towards the patient. "Look, I'm leaning now." Mirroring. "Oh, that must be difficult. How did you cope with that?" So facial expressions. "Look at my facial expression. How did you cope with that?" So empathic gestures. And then the next, let's go to the next one. So I just put the camera off here. So "oh dear," most commonly used. So brief sentences. There could be brief sentences, and there could be long sentences. "Oh dear," most commonly word. "Sorry to hear that." Oh, really? Oh, I'm really sorry to hear that. I see." So if the patient is laughing and genuinely laughing, say, for example, if the patient say, "Oh, you see, it's very sunny today, and my son's name is also Sunny." So you can say, "Oh, yeah, it is very sunny." So something like it's really humorous. You can just laugh at that, but try not to laugh. Just smile. Sometimes you have to. And how, when, as I explained in the beginning, how, when, how much, how many, explorative sentences starting from W and H. What happened after that? So they are the brief sentences to show empathy and concern. And so the next one will be long sentences. "Oh, I can feel your pain. I can imagine how painful it could be. I'm beginning to understand how that might have felt to you." So I can understand that must be difficult. That must be really distressing. It's not easy. It's hard. It must be difficult. Most of the people find it very hard. You must be a brave person to bear all this. So, what one of our course organizers, Dr. Gosal, he's dead now. He had a great sense of humor, and he said that when the CASC candidates come in a CASC station, they start saying distressing, distressing, distressing. So he says distressing 1, distressing 2, distressing 3, distressing 4. So don't say distressing, the word distressing again and again. Once it's fine, but like upsetting must be difficult, that must be upsetting, that must be annoying. So how did that make you feel? So like alternate between, vary between your sentences. Do not use stereotype sentence again and again. I can imagine anybody in your place would be quite distressed. That must be really frightening. A patient who is having delusions or hallucinations, you can use the word frightening. Do you ever cry while going through all this pain? So explore depressive symptoms in an empathic way. And crying spells. Now in Pakistan they say weep, but in Britain and Ireland we use the word cry for rona. So and weeping is generally not used except for if the ulcer or the boil is weeping, in those contexts, in the medical jargon sometimes. So crying is the most often used word. Anybody in your place would obviously be very upset. That must have been very difficult for you. I'm beginning to understand how awful that felt. Now, if you are, so that's it for my presentation for the English speakers, and I would like to say something to the natives, to the trainees from Pakistan and India. So this is written in Urdu, but like if I say some of the words are used in Hindi as well. So बेसिकली जो इसमें कहा जाता है कि हमदली के अल्फाज क्या हैं, कि जिस तरह से प्रोफेसर साहब जो कराची के हैं उन्होंने कहा हमदली, इसका तर्जुमा किया जाए एम्पैथी का, तो हम इसको मंजूर करता हूँ. हाँ, हमदर्दाना अल्फाज यानी हमदर्दी जो है ये एक ऐसा जज्बा है कि जो तंज के तौर पे भी यूज हो सकता है और पॉजिटिव मुस्बत मानों में भी. तो नेगेटिव मानों में भी तो ये होगा ना कि ओह मुझे आपसे पूरी हमदर्दी है, मेरी हमदर्दी आपके साथ है. नाउ यू आर सेइंग दैट इन अ सरकास्टिक वे कि जी आप तंज के तौर पे तंज कर रहे हैं लेकिन अपने दोस्त पे, लेकिन आप कभी कहते हैं ओह मेरी हमदर्दियां हैं उसके साथ, मेरी दिली हमदर्दी आपके साथ. तो ये बेहतर है कि ये लफ्ज़ ना इस्तेमाल करें. तो लेकिन ये कि पॉजिटिव भी हो सकता है, और ये इसलिए मैंने ब्रैकेट में लिखा है कि हमदर्द मेडिकल कॉलेज फॉर एग्जांपल. तो ये पॉजिटिव वर्ड है तो ये यूज़ किया गया, लेकिन ये नेगेटिव मानों में भी इस्तेमाल होता है. इजहार एहसास के अल्फाज क्या हैं? मुख्तसर अल्फाज. ओहो मैं समझ रहा हूँ. मरीज का जो मज़ाहिया कोई उसने तबसरा किया तो उस पर आप थोड़ा सा अगर हंसना बनता है तो हंस लें, नहीं हंसना बनता तो ना बने. ऐसा ना हो कि आप मरीज के ऊपर हंस रहे हो, ऐसा नहीं करना. ओए होए, ओहो, जी जी मैं समझ रही हूँ. अच्छा अच्छा अच्छा. फिर इसके अलावा डॉक्टर नासिर साहब फरमा रहे थे उस दिन, इसके अलावा और इसके बाद कब, कहाँ, कैसे हुआ, कब से, क्यों, ऐसा क्यों हो रहा है, क्या क्या हुआ. پھر کیا ہوا جناب؟ جی فرمائیں. جی جناب. جی فرمائیے. اچھا پھر کیا ہوا اس کے بعد؟ ایکسپلوریٹری سینٹینسز جو ہے نا وہ آپ پوچھیں گے. پھر اس کے بعد جو لمبے جملے، لیکن ہم لوگ پاکستان میں یہ چیز اتنے فالو نہیں کرتے، تو میں آپ سے التجا کروں گا کہ اس چیز کو فالو کیا کریں. کچھ نہ کچھ مطلب یہ کہ آپ یہ سارا تو کر رہے ہیں جو اوپر والا ہے، کہ آپ ایکسپلور بھی کر رہے ہیں، آپ یہ بھی کہہ رہے ہیں او ہو، اور آپ جو ہے وہ اپنا اس طرح لین فارورڈ بھی ہو جاتے ہیں، اس طرح اپنے ٹون آف وائس آہستہ بھی کر لیتے ہیں. او ہو اچھا، او ہو، یہ تو میں سمجھ سکتا ہوں. اوئے ہوئے اچھا. اوہ. لیکن اس کے علاوہ کچھ منہ سے بھی بولیں تو اس میں یہ ہے کہ میں آپ کے درد کو محسوس کر سکتا ہوں، میں سمجھنے کی کوشش کر رہی ہوں کہ آپ کس قدر کرب سے گزر رہے ہوں گے. میں سمجھ سکتا ہوں کہ آپ نے بہت مشکل حالات اور کیفیات کا سامنا کیا ہے، بہت کٹھن حالات کا سامنا کرنا پڑا آپ کو، اور یہ واقعی ایک پریشان کن کیفیت ہے. مجھے اس بات کا کسی حد تک ادراک ہے، اگرچہ آپ ہی بہتر جان سکتے ہیں کہ آپ کس درد سے گزرے. یہ آسان نہیں ہے، بہت مشکل ہوگا یہ سارا وقت آپ پر. میں تصور کر سکتا ہوں کہ آپ کی جگہ کوئی بھی اور ہوتا تو وہ بھی بہت پریشان ہوا ہوتا. آپ کو کیسا محسوس ہوتا ہے جب آپ آوازیں سنتے ہیں؟ میں اندازہ کر سکتا ہوں یہ بہت خوفناک تجربہ ہوگا. کیا آپ کبھی بھی اس سارے درد اور تکلیف سے گزرتے ہوئے رو پڑتے ہیں؟ کیا کبھی آنکھ میں آنسو بھی آ جاتے ہیں؟ اور اس کے بعد آپ ڈپریشن کی جو علامات ہیں اس کو پوچھیں گے. بہت افسوس ہوا کہ آپ کے ساتھ ہی کچھ پیش آیا. آپ کو تو بڑی مشکل پیش آئی ہوگی. تو آپ اکیلے تھے اس سارے. ہاں اندازہ کر سکتا ہوں تنہائی میں رہنا آسان نہیں ہوتا، بہت مشکل وقت ہوتا ہے جب کسی پیارے کا انتقال ہو جائے. ہم یہاں آپ کی مدد کے لیے موجود ہیں، تو آپ سے مزید بات کرتے ہیں اور پھر ہم جائزہ لیں گے. سر ڈاکٹر ناصر صاحب فرماتے ہیں ہم جائزہ، پہلے آپ سے ہم بات کرتے ہیں، پھر ہم جائزہ لیں گے کہ اس مسئلے کا بہترین حل کیا ہو سکتا ہے. تو یہ ریفرنسز ہیں جناب میرے، کہ پروفیسر ناصر سعید خان صاحب کے ریپور اینڈ ایمپتھی پہ جو لیکچر تھا، پھر کوئنٹن ڈیلی کی پوڈ کاسٹ 2006 Royal College of Psychiatrists, and then Kaplan and Sadok Comprehensive Textbook of Psychiatry, Calc for CASC course, RC Psych 2014, then Seshni Moodlier passed the CASC course, Gurpal Singh Gosal late, he used to run Super Ego Cafe course, and Oxford Psychiatric course 2014, which I really found to be very helpful. So that's all for today, and I hope you liked my presentation, and please share your comments. Subscribe to my, every YouTuber says, and I'm also saying that, subscribe to my YouTube channel and press the bell icon. Thank you very much, and talk to you soon again with some other lecture. Bye bye.